recorded here. All right, is everybody able to see my PowerPoint here? Give me 1 second to where, geez. All right, is everybody able to see that? Chapter 15, airway ventilation and management, or airway management. Perfect. All right, so when we talk about airway ventilation and airway management and the active ventilation and the active airway management, we're really talking a little more in depth at the paramedic level than just ABCs. Granted, ABCs is the basis, is the foundation of what we do for airway management and ventilation and how we truly manage our patients, you know, and verifying that they have a patent airway and verifying that our patient's breathing and looking at potential causes that could disrupt either one of those, whether it be the mechanical process of ventilations or the, you know, respirations at the cellular level. Something could be inhibiting what's going on with our patients. So we'll kind of breach the surface a little bit on that. Like I said, we're not going to go too advanced with stuff tonight on your guys' first night. We'll actually do that a little bit later on, probably our 5th week, I'm guessing, where we'll talk about intubation and everything like that. So who can tell me, one of the things that pulse ox, who can tell me how long it takes on average for a pulse ox to change? Say you've got a patient, pulse ox reading is 99%, they've stopped breathing. How long does it take on average to change? Just a guess.
A couple
A
minutes.
minute.
15 seconds.
Okay. So you guys will spend a considerable amount of time in the operating room, in the OR doing intubations, talking with anesthesiologists, learning airway manipulation and airway management. One of the biggest lessons that I was ever taught was purposefully, the anesthesiologist in front of me stopped bagging his patient. And he said, I want you to do me a favor. I want you to watch the pulse ox and watch the timer. So the patient started at 100% because we were bagging her on high flow O2. And 3 minutes go by, and this patient had dropped to 98% after 3 minutes. That's really kind of when I understood that pulse ox might not be as reliable as we think it is. That's when you'll hear me preach time and time again to use end tidal monitoring, because end tidal is like real time. We'll kind of breach the surface on this as well, but I just want to kind of get that in your minds right now that pulse ox isn't the most accurate thing all the time, just for the simple fact that it takes a little bit of time before your body really starts to show those signs to where your pulse ox is able to read on it. So it is a little bit delayed. What is the difference between airway respirations and ventilations? Well, I kind of said a little bit earlier, but what's the difference between a respiration and a ventilation? Anybody?
Ventilation is like the exchange of gas in the alveoli, and respiration is just breathing.
So it's actually the opposite or
Opposite.
opposite of what you said. So respiration is actually the exchange of carbon dioxide and oxygen at the, you know, alveolar level, as to where ventilation is actually the mechanical process of, you know, taking air in and letting air out, based off, you know, the positioning of our diaphragm, or are we, you know, negative pressure pulling air in, or are we blowing air out? So it's actually the opposite of what you think. Respiration is at the cellular level. Ventilation is more your mechanical process. So obviously everything we do, we should be checking airway patency. And when I say airway patency, we're looking to see if the patient is able, you know, we don't see any foreign bodies. We don't see anything that could be causing a total obstruction in our patients. And maybe it could be the patient's tongue that's inhibiting it. Maybe it could be teeth, whatever it might be. Maybe it's, you know, I've had patients before with throat cancer that, I mean, just to get an airway on them was the most difficult. And it was almost hard for them to maintain their own airway just based off a natural disease process that had happened with them. So when we talk about airway management, we have to truly make sure we have an airway before we can manage anything. So establishing that, maybe we're using an MPA, maybe we're using an OPA, maybe we're using, you know, a supraglottic such as a King device or an iGel or whatever it might be, but making sure we have the ability to create that airway before we move on. Brain death or brain injury can occur in as little as 4 minutes, depending on the patient. That's really not that much time when you truly think about it. Think of, for those of you that are on a volunteer department or a rural service or whatever it might be, you're dispatched out for a cardiac arrest. It takes you a couple minutes to get to the station, takes some time to get ready, takes some time to get out the door. By the time you get to the house, you're 12 minutes behind the 8 ball. Nobody's been doing CPR on this patient. We could potentially have a problem with those patients. And that's why, cardiac arrest, if you look at the statistics, sometimes we're not getting the best numbers when we're looking at, and I hate to say in our rural areas, I still work in a rural department. And it's not because we're not doing good compression. It's not because we're doing a good job. It's because of simple airway management and ventilation. We spend too much time on, well, we have to do this. I have to do this. I have to do this. Let's start with the basics. Let's start with our ABCs. Yeah, we should start compressions first, but then what? Everybody gets so caught up in, let's get AED patches on them. We have to do this. We have to do this. And as a paramedic, I pray you don't ever get in that mindset of, well, I have to start an IV first. I have to intubate this person first. I have to do this first. That is not true. We should default to our basics before moving on. So with our normal patients, we look at ABCs. With our patients that are unresponsive, potentially in cardiac arrest, we look at CAB. So we start with compressions, then airway, then breathing. Just for the simple fact that the act of compression is still moving blood. Blood carries oxygen. We are still oxygenating the vital organs at that point when we're doing compressions. It's a little difficult to assess an airway if the patient's not breathing. The only thing we can truly look at is if there is anything in their mouth, or maybe it's a traumatic event, something that could be leading to a total airway obstruction in that sense. So we have to kind of maybe bag them. Maybe that's how we can tell if we have an airway or not. Or we just automatically go to putting an NPA or an OPA in to see if we can get some sort of patency that way. So let me ask you guys, basic stuff. What is a contraindication to a nasal airway and why?
Any facial trauma.
Okay.
Like to the nose.
Okay. It really any trauma of the face. It could be nasal fractures. It could be a Lafort fracture, a Lafort 1, Lafort 2, Lafort 3, whatever it might be. But why is that a contraindication?
Airway can go up into the brain.
Yeah, so we could be ventilating the brain or oxygenating the brain, just not in the way we want, right? What about an OPA? What's our contraindications there?
Gag reflex.
Gag reflex, right? Or a conscious patient. How many of you have everyone put an OPA in a patient and they gag and you kind of do that move where you like step back and you're like, I don't know what to do. That because you're unsure. You can put an NPA in a conscious patient just as long as they don't have any sort of facial trauma. That honestly, an NPA is usually my go-to if I can. They're simple to put in. They maintain some patency. It might not be as much as we want, but I can still bag through an NPA and oxygenate my patient. Continually monitor and reassess airway. Reason that's brought up a lot, and I'll give you a good example for that is, let's say, again, we go on a cardiac arrest. Maybe we're just bagging this patient with an OPA or an NPA. We have to backboard them. We have to go down a flight of stairs, up a mountain, down the mountain, all the way to the ambulance. We get them in the ambulance, and now we realize that they're turning blue, a little bit gray, maybe blue, but we haven't reassessed their airway. We did a lot of movement, but we haven't really truly reassessed their airway. So continually assess and reassess. Have a way, especially if you're going to use some sort of airway device such as a King or an iGel or an LMA, whatever it is, have a backup and have a backup to your backup. So maybe you're going to go an iGel, your backup should be an OPA, your backup to that should be an NPA. Have multiple ways that you can, or multiple things that you can turn to in case things go south. Some of this stuff might make sense. Some of this stuff might seem confusing to you, but I promise you, we'll get you to a point where it's very stuck in your brain, where you just can't not think about it. Especially when we start talking about acid-base balance, it's a little confusing at first to understand, especially if you don't know anything about acid-base balance. But I promise through this whole semester, you'll kind of feel like you're lost with it. I promise we'll get it to where you understand it fully. So anatomy of our respiratory system for our adults and even for our pediatrics. What is the difference between an adult and the peds when we talk about anatomy of the respiratory system? What are some key differences?
They're different sizes.
Okay. What else?
Peds are a lot softer and underdeveloped.
That's exactly what I was looking for. Softer and underdeveloped. Because they haven't fully grown yet, right? As an adult, if you feel your neck right now, you feel your trachea, you feel cricoid rings, I'm guaranteeing. Those little bumps along your trachea, those are your cricoid rings. Kids don't have those. Their airways are very soft, they're very pliable. That means they're also a lot easier to obstruct. It's the same thing with, you know, bones in kids. They're not fully developed. That's why kids, I always said they're like those toys they were like inflatable things when I was a kid that had like sand in the bottom. You could punch and it'd bounce back up. It's like a kid. They can fall down, get hurt, and stand right back up. As to where if I fell and did that, I'd probably break a hip. They're very pliable. So what does that mean for our airway system or our respiration system or respiratory system? Should we know as providers going into this if we're going to a PEDS call? We should know there's a greater potential that there is airway closure in a child. And maybe it's a traumatic situation. Maybe it's something as simple as an anaphylactic reaction. So our respiratory system and the structure provides passage for our oxygen and carbon dioxide. That's what our lungs are for, right? We bring in fresh oxygen, we exchange it, carbon dioxide comes out. That's layman's terms for how our body works, right? Our upper airway, mouth, nose, down to our larynx, nasal cavities, oral cavities, pharynx, and then you have your lower airway, which is like your lungs, you know, your alveoli. You know, I actually got a diagram here that explains a lot more of our upper airway. So we have obviously our nasal cavity, we have our mouth, and towards the back, obviously past our uvula here. God, I know that I can get like a little laser pointer. Here we go. So our uvula. And then we join, right? Nasal cavity and mouth join back here. So everything has a structure, everything has a name. Glottic opening. Has anybody ever seen a glottic opening before? Maybe in a training or something like that, or maybe a class you went through, or maybe, you know, you were able to see it when a paramedic was intubating somebody or something like that. Has anybody ever seen that before?
Yeah, I see it quite frequently in the ER.
Yeah, sure, absolutely you would. Moving down, we have our vocal cords. Obviously, our vocal cords, when we talk a little bit more about intubation, they are a landmark for us in terms of intubation. We have our thyroid cartilage and our cricothyroid membrane right here. What you'll notice is our cricothyroid membrane is unprotected as to where this cartilage isn't over it. What that means is that was where we usually do a needle cric or a surgical cric to get an airway on a patient that has either such traumatic damage to their face, or we're just unable to get an airway totally. We could turn to a cricothyrotomy of some sort. Your cricocartilage and then your thyroid gland. So nasal cavity. Does anybody know what actually our nose does before it brings air down to our lungs?
Filters air and moistens it.
Filters air and moistens it, right? So I know that sounds kind of weird, but that's literally its job. We had hard and soft palates. We have our tonsils, our uvula, which is obviously our whatever you want to call it. I always call it our little bell that hangs in the back of your throat. Tongue. Our tongues are massive, and they are actually the #1 obstruction in unresponsive patients because our tongues flop backwards over our airway. You'll see this void here called the vallecula. And what the vallecula is it's actually a void space that we can actually use and that we do use when we're intubating. Whether it be, you know, we're using a certain type of blade, we can actually use that vallecula as a means for guiding our ET tube down. You have your epiglottis. your esophagus, which obviously lays posterior to your trachea. Trachea is always in front, esophagus is in the back. So like we said before, sinuses are our nasal cavities lined with mucous membrane, trap bacteria, and other substances. It really acts as a filter system. Is anybody familiar, or did anybody know that your eustachian tubes actually connect your ears to your nasal cavity? Anybody know that was a thing, that they were connected? I didn't for the longest time, actually until I was in the OR and we started talking about it. There are small little ducts that actually connect your ears to your nasal cavity. It's a little odd, but they're called your eustachian tubes. Nasal lacrimal ducts drains tears and debris from eyes into the nasal cavity. You know, if you've ever heard the term lacrimation, that's essentially crying. So we do have lacrimal ducts in our nose as well to allow for drainage. That's why a lot of times, you know, if you see a child or somebody that's crying really heavily, it seems like their nose is running at the same time. A lot of that is because they're actually draining into the nasal cavity. So obviously when we breathe in, air enters the nasal or external nares. I shouldn't have to go too in depth with that. That's pretty self-explanatory. Gums, teeth. Teeth is actually another concern when we're talking about airway obstructions, especially in our geriatric and older populations that might have dentures or might have teeth that are really fragile. That can always be a means for creating an airway obstruction. So one of the things we need to do is, if we're going to look at managing their airway, if their denture is able to be removed, we need to probably look at removing those so they don't cause an issue later down the line. One of the things that you guys will spend a lot of time with is airway in first semester. We will cover airway nonstop first semester. We're talking about basic airway maneuvers, talking about innovations, talking about Kings, iGels, LMAs. We're going to go through everything, and we're going to do them pretty frequently during your guys' skills night. When we talk about our pharynx, you have a nasopharynx, so obviously naso meaning nose, oro meaning mouth, and laryngopharynx, which is actually a little bit lower down. So naso, oro, and laryngopharynx. Gag reflex, body's cough and swallowing mechanisms. Everybody, the reason I kind of laughed a little bit is last class, we actually had a person that has a really shallow gag reflex, and it was actually a birth deformity that they had. And I don't know how that actually came up in a conversation, but that is your body's natural reaction to something entering that is not natural, is to either try and cough or shove it back down into your stomach, almost like when you're vomiting. That's actually that feeling. Have you ever felt like you're gonna vomit in your mouth or something like that? That's the exact thing of what's happening there. Is your body's actually digesting it again. Adam's apple, thyroid cartilage. In males, obviously, it's more prominent. Our laryngeal cavity contains our vocal cords, which I'll actually pull up a picture of here shortly. Has anybody ever asked, maybe during code or something like that, as an EMT, has anybody ever said, I asked for cricoid pressure or maybe to perform a Selleck's maneuver? If you guys have ever heard that? So what they're asking for is essentially you to grab that thyroid cartilage in the person's neck and push down on it, push pressure on it. What you're actually doing is you're pushing pressure on the esophagus through the trachea to stop any air from entering into the esophagus, because air introduced into the esophagus enters the stomach, which actually gastric upset occurs, and then we see vomitus come up the airway. Cricothyroid membrane we'll go over a little bit later in our skills lab. So why is this a concern? And with the CCP class that we went over, one of the things when the critical care class that we cover is surgical airways. And one of the things that one of the students had brought up was it makes me a little bit nervous putting a scalpel essentially in the middle of somebody's neck, because we have vessels, right? Does anybody know, you should know, where do our carotid arteries and jugular veins run? Are they on the left side? Are they on the right side? How does that work?
They're on both sides. They're on the left and right.
Okay. Anybody else? They are on the left and right side. Obviously, we don't ever want to puncture an artery, especially carotid artery, just for the simple fact that there's a massive amount of blood that flows through that to our brain. Jugular vein is a little bit different story. You know, if you've ever seen somebody start an IV, maybe if they've ever done an EJ or an external jugular IV, that is still a vein and it's still a place that you can get access. It's just it takes a little bit more practice and takes a little bit more time. But you're correct; they do run on both sides. That's why if you're feeling for a pulse, you generally feel 1 inch on either side of the trachea, and you can actually feel your carotid pulse. So when we talk about lower airway, when we talk about alveoli, what do you envision in your, like, what do you think alveoli look like?
They're like squishy. How do I say this? It's like a sack with a net over it that like makes like little balls on the outside. That's how I picture it.
That was very descriptive.
Sorry.
Anybody else? How else do you picture it? Honestly, how I think of it is I think of grapes. To me, that's how I, you know, if I was able to look down into somebody's lung, that's what I imagine it would look like. Obviously not grapes, but I'd see little grape clusters like your alveoli. Now, what those alveoli are doing is they do have a capillary bed on them. In a capillary bed, does anybody know what a capillary bed does? What's the purpose of a capillary bed?
The exchange of oxygen and CO2.
Yeah, so our capillary bed is met essentially where an artery meets a vein. It's broken down through arterioles and venules, broken down into such small vessels that it meets this capillary bed. Each one of those alveoli have a capillary bed, and that's where we get that exchange of oxygen and carbon dioxide, you know, bringing in the oxygen, letting off the CO2, and we're able to make a respiration occur. Our trachea divides into right and left main stem bronchus, and this will become very important for you when we start getting into intubation, as far as how the intubation can go wrong, just for the simple fact that if I'm going to put a tube down this diagram right here, starting at the top, our hyoid, through the tube, which side is that tube going to go down most likely if I keep pushing it?
Right.
Why is that?
Or straight on.
Okay, and that is exactly how it is on patients. It is more of a straight shot than the left. The left actually has to curve. So if you've ever like heard or maybe been in the field with somebody that's been intubated and they're like, okay, you have breath sounds on the right but nothing on the left, it's generally because they pushed the tube too far. So usually they have to pull back the tube a little bit and then they'll get bilateral breath sounds. It is 99% of the time, if they're going to go main stem intubation, it's going to go down the right side. And I've actually got a video that I'll see if I can play for you guys later on, that kind of shows you some of these structures as well. So right here, you've got your thyroid cartilage right where my laser pointer is, or cricoid cartilage. See this little indent right there where there's soft tissue in the middle? That's your cricothyroid membrane. That's the spot we shoot for when we talk about a cricothyrotomy. And then obviously you've got your cricoid rings as you go down the trachea, your carina, where we branch off into our right and left trachea or main stems, down into our lung tissue to our alveoli. A little diagram of what the inside of them would look like. And you can actually see this when we perform an intubation on a patient. You can actually look past their vocal cords and see down their windpipe essentially. What you'll notice is a lot of structures when we talk about in paramedic school, whether it be the heart, whether it be lungs, whatever it might be, there is usually always a mucus lining in between tissues. Does anybody know why there would be a lining of some sort of fluid or some sort of mucus in between tissues?
Allow for easier movement.
Yeah, otherwise we get friction, right? And friction can cause pain. That's why you get some patients, and I'll just tell you, you get some patients that, maybe they're having trouble breathing, and that's why they're leaning forward. They're in the tripod position because the tripod position actually swings their lungs forward in their chest cavity. And if they have any sort of friction rub in between their lung linings, this takes that friction rub away because now the lungs aren't the tissues aren't laying on top of each other. Now they're kind of free floating. So that's why some patients might be in the tripod position, as it's less painful for them to breathe.
Does that work as well for somebody that's got like pleurisy?
That's exactly what it is. Yep.
Okay.
And if you've ever heard of somebody that has like, pericarditis, where the lining they have an infection, a lot of times the lining around their heart that fluid will actually disintegrate. And so a lot of times as well, when they're having chest pain, those patients might lean forward as well, because when they lean forward, it's taking pressure off that lining. So, but when we get into cardiac, we'll talk a lot about that. So right mainstem off inside of aspirated foreign bodies, and we could see why. It's a straight shot down our trachea. Our bronchioles terminate at the alveoli. Our alveoli are the essentially last stop on the train of our respiration system. Oxygen carbon dioxide gas exchange takes place in the alveoli. And then we talk about atelectasis, which is alveolar collapse. Does anybody know when we could see atelectasis happen?
Emphysema patients.
Okay, why?
The alveoli are dead from not able to, well, no, I'm saying that wrong. I guess COPD would be more fluid filling them. Emphysema would be dead alveoli, I guess. I think I'm saying that right.
So how our alveoli work is they're essentially, when we get down and look at a little bit closer, they're these little, think of like a stress ball. It's really squishy. So when they open, they're letting out carbon dioxide, and when they close, they're pulling in oxygen, and then they just keep on redoing that, almost like a Venus flytrap, if that makes sense. Now, the problem is when we can get alveolar collapse where they're just not working at all. Think of a patient has CHF. What do you usually hear with lung sounds with those patients?
Crackles.
Okay, so what do the crackles indicate?
There's fluid in the alveoli.
Okay, not in the alveoli, but around them. Now, that's when we can get atelectasis because it's hard to move underwater. Those alveoli aren't able to pop open to get the oxygen they need, and there's no oxygen for them to grab. So that's why you'll see a lower O2 sat in these people as well. Now that's where your crackle comes from, is you're hearing the popping of those alveoli when they pop open. So how do we treat that then?
CPAP.
Okay, CPAP. We put them on CPAP. We push that fluid away from those alveolar space, and those alveoli are able to open freely. That's why those patients are often able to breathe a lot easier when they're on CPAP, is because we don't have that fluid. We've pushed that fluid out of the alveolar space and essentially into the walls of the lungs. And a lot of times we'll push it back into the vascular spaces. Pleura, you kind of brought up pleurisy earlier, connective tissue that covers the lungs. Everything that we talk about organ-wise has connective tissues or has a connective lining or a protective lining. We talked a little bit about PEDS, airways being smaller, more fragile. The thoracic cage is softer, more pliable. Now, what does our thoracic cage have to do with ventilation or respirations?
If you have broken ribs on one side, it can make one side of the chest rise and the other not, right?
Okay, so you're talking like a flail chest or a flail segment, right?
Right.
Okay. Now, a lot of times as well in those traumatic situations with those patients, maybe they've broken ribs or something, is it's really painful to breathe. So a lot of times in those patients, you'll see them take short but a lot of breaths. So short, rapid breaths, because a big deep breath hurts their ribs. So a lot of times they'll do quick in and out breathing. Capillaries, again, that's where exchange of carbon dioxide and oxygen is happening, where our arteries break down enough to where obviously we don't have these massive vessels. They break down into arterioles, meet up with our venules, which is a smaller vein, and they actually connect together to allow that oxygenated blood to exchange with deoxygenated blood, hence carbon dioxide. So when we talk about pulmonary ventilation, depends on changes in pressure within the thoracic cavity. What does that mean? What I guess you guys tell me what that means to you. It depends on changes of pressure in the thoracic cavity.
It works on like negative pressure.
Okay, elaborate.
So when your diaphragm relaxes, it allows the lungs to take that space because of the negative pressure generated, therefore have air come in.
So when our diaphragm lowers, air comes in, right? When our diaphragm rises, we're exhaling. That, and you can feel it on yourself. Take a big deep breath. You can feel your diaphragm lower, and when you blow all that air out, you can feel your diaphragm rise. So it's pushing that air out, and you're exactly right that we rely off negative pressure. As our diaphragm lowers, it's pulling air in. As the diaphragm rises, it pushes the air out. Coordinated action to get a respiration.
I have a question. Sorry.
Yeah, go ahead. Yeah.
Okay, so back to the diaphragm rising. Can you explain that again? I'm a little confused on the whole, like when you breathe in. I guess I'm just not understanding what you mean.
Okay. Question. Okay, let me put this in easy terms for you. Have you ever grabbed a syringe before with nothing in it, just air?
Yeah.
What happens if you? God, that noise gives me PTSD. What happens if you push the plunger of the syringe?
That it goes down and the air comes out.
Okay. What happens if you pull the syringe back down? Like if I grab a syringe and I pull the plunger out, what am I putting in?
Air.
It's this exact same thing with your diaphragm.
Oh, okay. All right. I understand now.
Yeah, as I'm pulling the plunger out, air is coming in. As I'm pushing the plunger, air is going out. Same exact thing.
Oh, okay. Thank you.
Yep. All right. Normal expiration is a passive process, meaning what?
You don't have to think about it.
You don't have to think about it. It happens naturally, right? I mean, sure, if you sit there and think about it, you can stop your body from expiring. We can hold our breath. Now, breathing in is an active process that takes a little more energy because we're actually having to burn calories when we breathe. Believe it or not, you do burn calories when you breathe. Why would respiration require an intact circulatory system? Why would we, I guess, need all of our vessels in place to get to have a good respiration?
Because if you're not getting blood to the lungs, you're not going to have that gas exchange.
Okay, so yeah, if we don't have blood to that capillary bed, we don't have that gas exchange. That's absolutely right. Heart pumps as much blood to the lungs as it pumps to the peripheral tissues. It's very basic 101 on how the heart works. Blood comes in through the right side of the heart. Blood travels from the right atrium through our tricuspid valve into our right ventricle, is then pushed out to our lungs. It is then oxygenated, pushed back to the left side of our heart and out to the body. It is a constant process of moving blood from the lungs to the body. There's no hey, we're going to stop breathing, or hey, we're going to stop pumping because I need to fill up this side of the heart. That's not how it works. It's an equal amount of blood going to the lungs as it is to the body. So if we look at our lungs, they're actually a lot closer to our heart than you think. Probably not this close, but so we have our great vessels. And what I mean by great vessels is we have our superior vena cava, we have our inferior vena cava. So our superior, obviously bringing blood to our upper extremities, our arms, our brain, and then we have our inferior vena cava, which is then able to bring blood, and then we have our aorta. Has anybody ever heard of an aortic tear or anything like that, or an aortic aneurysm?
Yes.
Okay, so this is where we're looking at right there. That structure right there in the middle. It is vital. It is a loop that essentially travels from our heart up and over, and it actually supplies our heart as well with its own blood because we have coronary arteries, which are these right here. The aorta also supplies blood to our heart so it can function. So when we talk about like chest pain and stuff like that, what we're seeing is these vessels actually having some sort of blockage. So the heart receives blood not from itself, but the blood actually travels through the aorta and then back. It's a loop essentially. And then we have pulmonary veins, pulmonary arteries, which we'll dive a little bit deeper in when we get into cardiology. All right, before we hop into this section, let's take like let's take a 10-minute break, and then we'll come back and get into our gases and our lung exchange. So take 10 minutes, and then we'll get back. All right, we'll go ahead and get going again. All right, Nate, you there?
Yep, I'm here.
All right, tell me how much nitrogen you think is in the air that we breathe, percentage-wise. Take a guess.
I'm not really sure.
Okay. Let's see. Hey, Joel, how about you?
70%.
Close, close. It's right around 75%. 75% of the air we breathe in is generally nitrogen. Oxygen, everybody throw out a number. Somebody give me a number. How much do you think is oxygen?
21%.
It's actually less than that. When we look at true numbers, it's closer to 14 or 15%. What about carbon dioxide? Carbon dioxide makes up about 5%. Water makes up about 6%. So our partial pressures, and I should have kind of said this a little bit in a different term. I'm talking the air that comes into our lungs at that point, not our atmospheric. Atmospheric, we're looking at 21% oxygen, closer to 79% nitrogen. When we look at torr, what you'll see here is just another way of saying it's a partial vacuum. Whenever you see torr behind a number, it's referring to a partial vacuum pressure. So with that being said, looking at these numbers, at the alveolar space, at the alveolar capillary bed, 13% oxygen really isn't that much. That's why we breathe as much as we do. That's why we constantly are exchanging carbon dioxide and oxygen, just for that simple fact. So diffusion, movement of gas from an area of concentration of high concentration to an area of lower concentration. Somebody give me a good example of that. Something that moves from a concentration that is high to a concentration that is low. It doesn't have to be a gas, just for the example.
CO2 into the bloodstream.
Okay. What's another one that it's easier to think of? An easy way to put it and to remember diffusion, it's not a gas, but it works in the same concept, is if I drop a cube of sugar, a whole cube of sugar, it's compacted into a cube, right? It's highly concentrated with sugar. If I drop that cube of sugar into water, what happens? It dissolves, right? It dissolves into the water and makes the water sweet. It goes from high concentration, that cube, to low concentration because the water didn't have any sugar in it. So it dissolved itself to almost maintain an equal amount throughout the whole system, throughout the whole glass. That's kind of how diffusion works. When we talk about SaO2 or PaO2, what we're talking about there is saturation of our arterial blood. Anytime there's an A, we're talking arterial. So especially when we're drawing like blood gases, or maybe we're drawing, simple labs or something like that. You guys will see a lot of these numbers during your clinical time, especially in the hospitals. So that's what that is referring to, is the amount of oxygen actually in the arteries. It could be 80%, it could be 70%, whatever it might be. When they say SaO2 or PaO2, they're referring to either your venous or artery oxygenation levels. I promise it gets a little more interesting when we get a little more slides past this. Hemoglobin carries vast majority of oxygen in the blood. That is what oxygen attaches itself to. So if somebody is low on hemoglobin, i.e., somebody's anemic or they have severe bleeding or hemorrhaging, what can happen to their pulse ox reading?
It can go down.
Okay, it kind of makes sense now as an EMT why we're taught in traumas to put high flow O2 on somebody, right? Because think about it. As we lose blood, we lose the ability to carry oxygen. Problem is, we can put as much oxygen on those patients as we want to. It's not going to do anything if we don't have the means of carrying it throughout the body. Also, inadequate alveolar ventilation. So maybe it is a case of atelectasis, alveolar collapse. We are not getting that process. We're not getting them opening and closing. They're just collapsed, so we get nothing. One thing you'll often hear is a ventilation perfusion mismatch. And you might hear it referred to as like a VP or VQ mismatch. What does that mean? I ask you guys a lot of questions because I like input from people. I like to hear people talk. What do you think, and I don't expect you guys to know all these answers, what do you think a ventilation perfusion mismatch means? And I'm not watching you, so please, for the love of God, don't go on Google and look it up.
You're getting a lot of breaths, but you're not you're not oxygenating hemoglobin enough.
Okay, so give me an example.
Like if you're hyperventilating, you're ventilating a lot, but it's not actually making a good gas exchange, so you're retaining a lot of CO2.
Okay, could you see that in trauma as well then?
Yes,
blood?
absolutely.
It's either, and you're absolutely right, it's either you're receiving a lot of O2 with limited blood flow, or you're receiving a high blood flow with limited O2. It can go either way. Meaning one of the processes is impaired, whether it be metabolic, whether it be trauma related, whether it be whatever it might be, a substance causing ventilation mismatch, possibly due to unresponsiveness. You got to think in cardiac arrest as well. You know, if it's a patient that just collapsed in cardiac arrest, their heart stopped beating, but they might have those last respirations that their body's giving out. That's also a ventilation perfusion mismatch. So how do we try and correct that? Either we have to increase pressure because we're not getting correct oxygenation, or we have to increase the amount of blood that the patient has. Maybe with if it's a trauma, that's when we're looking at stopping bleeding or stop the bleed, to where we can start to get some sort of perfusion going on with these patients, so we can have that hemoglobin to carry that oxygen. One of the things that we'll teach nonstop is that I teach nonstop is that you can fill somebody up with saline as much as you want in trauma situations. But what is saline? I mean, really, what is it?
Salt water.
It's water, right? What is that doing? Is it doing more harm than good in a trauma at some point?
Eventually,
so that's when we look at, and again, we'll talk about this later, but we look at what's called permissive hypotension, because to increase blood pressure so much during those situations to where we're thinning out their blood so much that they're not oxygenating at all. They're not carrying the oxygen they should with their hemoglobin because they don't have it. Blood transports carbon dioxide in the form of bicarbonate ions. So how do we correct bicarbonate ions? How do we try to counteract that? We'll talk about that later, but just think of that. Hyperventilation lowers CO levels. The normal CO level within our body is 35 to 45. If we put somebody on end tidal, we expect to see a number of 35 to 45. That is normal carbon dioxide levels within the body. Now, if somebody breathes too fast, the carbon dioxide lowers, right? Because we're blowing all of it off. What if somebody's unresponsive? What happens to that number?
It goes up.
Climbs. Good example is I had a patient 2 weeks ago, unresponsive, COPD, having really bad difficulty breathing. We got him somewhat responsive, got him to the stretcher. He went out completely, put him on end tidal monitor. His end tidal number was 150. What does that tell me? If normal is 35 to 45, what is 150? What does a high number tell me?
He's
not breathing, right? He's not perfusing. He's not getting a good ventilation perfusion match. Something isn't working. And in his instance, he just wasn't breathing. So some things that can increase carbon dioxide production is fever, because it takes a toll on metabolism, muscle exertion, shivering, and some other metabolic processes such as blood sugar issues can take a toll on CO2 as well. That's why if you've ever seen a diabetic that has Kussmaul respirations are big, labored, deep breathing, right? Big. It's because they have a buildup of carbon dioxide because the sugar, so their body is naturally trying to blow off that carbon dioxide. That's what a Kussmaul respiration is. So on the other end of the spectrum, this can be caused by drugs, right? It doesn't have to be metabolic. Especially in our opioid overdoses, which we see more common than anything now, we can see respiratory depression. How many times have we been told, especially with Narcan, or have you heard, well, we give enough just to get the patient breathing. We don't want them to wake up. Has anybody ever heard that?
All the time.
Why is that?
To want to be combative.
But what's causing that combativeness?
Fusion.
It's an excess of carbon dioxide because those patients weren't breathing as well. So you'll see some medics will actually, before they give Narcan, put N-Tidal on their patients and bag them down because the likelihood of them waking up combative is less likely. Because their brain was under stress, so they wake up combative. It's not Narcan that's doing it. It's not because you took away their high. It's because they have a buildup of carbon dioxide in their brain. Airway obstruction can also cause an increase in carbon dioxide. Impairment of respiratory muscles. That COPD patient that just gave up. If you ever had a patient that just, I'm tired of breathing, I can't breathe anymore. It's just they're going downhill fast. They're turning pale. That's an impairment of respiratory muscles. Obstructive diseases, emphysema is a good example. With emphysemic patients, have you ever seen them create their own back pressure where they whistle essentially with their mouth? Because that's literally how they're able to get rid of the air. They essentially make a small opening with their mouth when they exhale. Has anybody ever seen that with a patient? Or pursed lip breathing, I believe is what it's called. Next time you have somebody with emphysema, watch. It's more common than you think. Hypercarbia is the term that we use to define increased carbon dioxide levels. Hypercarbia. Anything hyper means elevated, hypo means decreased. So hyperglycemia, elevated blood sugars, hypoglycemia, low. Respiratory rate, this is back to EMT school. Number of times a person breathes in 1 minute. What is the average adult respiratory rate?
$12 to $24.
Okay, 12 to 20.
12.
Where are the 4? 12 to 20. Now, how we breathe, essentially, and how our body knows to breathe is controlled in our medulla, located in our brainstem. So why is that a concern? In some traumas, we could lose the ability for the patient to breathe. Our body also, or our lungs also contain what's called stretch receptors, meaning they will take in as much air as they can until their lungs say, hey, that's enough. I can't stretch anymore. Or I'm at my limit. I can't take any more air in. And your body will naturally exhale at that point. Chemoreceptors. So chemoreceptors are how we tell if we have an elevated level of carbon dioxide. Our body will naturally go, okay, my carbon dioxide is above 45, because normal level is 35 to 45. Our body will say, okay, I'm at a level of 60. So what do you think our body does at that point? If we have a high level of carbon dioxide, what does our body do?
Increase your breath rate.
Increase respirations, absolutely. And then what about hypoxic drive? What is hypoxic drive? What does that mean? Where could we see that with patients?
Primarily in COPD.
Okay, explain a little bit. Why were they relying off hypoxic drive?
Because people are so used to being hypoxic for so long that the body kind of naturally adapts.
Yeah, so these are the patients we see with COPD that are in the 80s, 82, 83 range. That's their normal. What happens to these patients when we put them on 100% O2 and we try to get them up to 100%? What happens to them?
You knock out their drive to essentially breathe.
Okay. Yeah, that's exactly right. We actually do more harm than good with these patients. That's why COPD patients, one of the first questions I always ask, they will know what their pulse ox level is. If they have some severe COPD, they will know what they normally sit at. And that's what I try to keep them at. I'm not trying to overload them with oxygen because oxygen is actually harmful in large amounts. And why is that? Well, pulse ox only measures up to 100%. We can give way more oxygen. That just means 100% of our hemoglobin are saturated. And pulse ox is very deceiving in that concept. When we think of like CO poisoning, what do you think that person's pulse ox is? It's still 100% because their hemoglobin is saturated 100% with CO. It doesn't necessarily mean oxygen. It just means their hemoglobin is saturated. It's the percentage of hemoglobin that's saturated in the body. That's why you got to be careful. You go to a house fire, they bring this patient over to your ambulance, they're having difficulty breathing. You put them on a pulse ox, it says 100%. You're like, well, I'm not going to put you in oxygen. Your oxygen level's fine. Put them on end tidal, then see what it looks like. It's a totally different story. Other factors that affect respiratory rate, obviously fever, because it is metabolic, so our body can naturally alter our respirations to try and fight the fever. Emotion. Who's been on a call before? Difficulty breathing, 27-year-old male or female, they feel like their arms and legs are going numb. What's happening there?
Hyperventilated.
Okay. Due to what? Generally.
Anxiety, panic attacks.
Yeah.
That numbness they're getting in their arm or legs is carpal pedal spasms from a buildup of carbon dioxide. Or not a buildup, sorry, decreased carbon dioxide. Pain can increase a lot of things. Pain can increase your heart rate, it can increase your respiratory rate. Hypoxia obviously is going to affect your respiratory rate. Acidosis, which we'll get into a little bit maybe in a slideshow. Drugs, whether it be an opioid or an upper or downer, whatever it might be, can affect your respiratory rate. And then sleep. I'll be the first one to tell you I have horrible sleep apnea. I snore like you wouldn't believe. So at night I tend to breathe less than I do during the day because of that. Some capacities and measurements. When we talk about total lung capacity, we're talking about how much air can totally fit in our lungs, TLC. Tidal volume, you'll see abbreviated as VT. Dead space volume, VD. Alveolar volume, VA. Minute volume, VM. Alveolar minute volume. Does anybody know on average how much air the adult lungs hold?
500 to 600 milliliters.
That's about right, 600 mLs of air. So question for you guys, an adult BVM, how much air is in an adult BVM?
Is it 1,000?
1,200. An adult BVM has twice as much volume inside of it than our lungs do. So let's put that in perspective now. We go to bag somebody, how much should we really be truly squeezing that bag? Half or less. There's studies out there now saying, you know what, maybe we shouldn't even be using adult BVMs on adult patients. Maybe we should be using child BVMs because we're hurting our patients. What happens when we increase pressure in the chest? When we overventilate our patients, what happens?
Goes in the esophagus.
Okay, so we gastric upset. What else? Let's put this into perspective. Our great vessels, we have our aorta, we have our superior vena cava, we have our inferior vena cava. If I am to increase pressure around them, therefore putting pressure on them, what happens to my blood pressure?
Drops.
It drops. So by overventilating our patients, we can potentially see a drop in blood pressure. Something we don't consider. Inspiratory reserve volume. expiratory reserve volume, we always keep some reserve in our lungs. Why? Because it's easier to inflate a balloon that already has some air in it than to inflate it from nothing. Residual volume, forced expiratory volume. We'll talk about PEEP at some point when we get into innovations. Common causes of our airway obstructions. Again, this is basic stuff. Our tongue, foreign bodies, trauma, laryngeal spasms and edema, aspiration, vomit or blood. Airway obstruction, partial or complete. Tongue is most common cause of airway obstruction. Let me see if I can get this video pulled up for you guys real quick. So give me 1 minute here while I try to get this pulled up. And I'm hoping you guys are able to see it.
What's your
Trying to get it so I can share my sound on here. Anyway. All right, can you guys see my desktop by chance?
Yes.
Okay. Can you see YouTube now or no?
Yes.
Yes.
Let me know if you guys can hear this or not. Still see it? Did you see me enlarge it?
Yes.
game day experience? Turbo tailgate, front row seat.
Can you guys hear that?
Yep.
Okay, perfect. I want you to, who watches Night Watch? Anybody ever
Me?
seen Night Watch before? I want you guys to watch this video. It's about 5 minutes long on a patient they had that was choking. And then we'll talk about it afterwards.
Then enter for a change.
What's your emergency?
If someone's choking, we're giving them the high blood. We need one out here immediately.
Okay, do we know what he's choking on? Tell me, is he able to breathe at all?
No. He's losing consciousness. He's not able to sit up
Okay.
anymore.
All right, I have fire and EMS en route to you, okay?
Blue, man. Keep blue. Blue.
Can you turn him on his side?
Yeah, we need help immediately.
Listen to me. We need to do the Heimlich maneuver again, man. You're gonna put your arms around his waist and make a fist for me. Grab it with the other hand above the belly button. Jerk really hard, and it's a quick motion up into his stomach. And keep doing that until he can breathe, talk, or cry. You're gonna have to keep going until they arrive. All right, ma'am. They're en route to you.
I'm headed to a person that was initially choking on a piece of meat and then went unresponsive and stopped breathing. So this sounds like a full airway obstruction, which can very rapidly then progress into respiratory and cardiac arrest. If it is a full obstruction, especially with food, you can try to, pull it out of their throat. See if we can ventilate them to the point where they start responding again and breathing. This is one of those true life or death moments where every second matters because there are two things that are happening. Number one, he's not getting any oxygen to his brain and to his organs. And number two, his heart's going to stop. Right here? Oh, yeah. 1, 2. Let me go. Don't do the Heimlich. You can stop. Don't do the Heimlich. We're gonna get him. Once a patient reaches the level of being unresponsive, they cannot support themselves in an upright position, and so the Heimlich maneuver is not appropriate anymore for this patient. Do y'all know what he's choking on? Get everything off, get his legs. You ready? Yeah, what? I am responding to a call for a male that is choking on a piece of steak. While choking, this patient started to panic, which is how he maybe ended up outside. He is unresponsive, purple from head to toe, and barely breathing. This guy has a full airway obstruction.
Airway roll, you can give it a deal.
All right, buddy. All right, we got you, man.
I know, you got it.
The first thing that I do is grab our video laryngoscope and the McGill forceps. So in being able to visualize what is in his throat, I can come in with the forceps, grab it, and pull it out manually. Oh, let go, buddy. Let go. There we go. Hold on. Okay. Oh, good. Sit up. Sit up.
Hey, man.
He's still got a large chunk of it in there.
Sit. There we go. Can you speak to us? Tell us your name. There you go. All right.
Can we try to put that oxygen mask on you for a minute, bud? All right, just take some deep breaths for now. And you're also going to feel some swelling and some things like that. So don't want you to keep coughing if we can't get anything up, all right? He's able to talk to us, but he doesn't really know what happened. He doesn't realize he just almost died. Well, yeah. I would, if this is what he's gonna do,
I'm just gonna go put
yeah, I would go to the hospital just because he's gonna have some airway swelling. They may want to just tube him. That's your family out there, buddy? I'm gonna go let them know just since they're so freaked.
What?
Hey guys, so we have the piece out. He's up. He's breathing on his own. Okay. We're gonna of course transport him to the hospital because I do feel there is still a piece in there, but he is up. He's breathing on his own and he's aware.
Okay.
Yeah, you can look at him for a second. They just want to look at him for a second, but we still have a lot to do. Okay. His outcome should be phenomenal. Without our intervention, this person could have very much been deceased. 3249, you can show me clear. So 3244, code 3 to university with one patient. Yeah, that was a bad one. That's what I'm going to have in front of it. Pull the whole piece of steak out your mouth. That's a sexy steak.
All right. So what did that guy look like when we first saw him? When he was laying on the ground, what did he look like?
Dang near dead.
What was his color like?
He was pretty pale.
Pretty pale, right? How quickly did his color change afterwards? Pretty quick. You know, I has anybody been on choking call before, like a total obstruction like that?
I just was like a week ago.
And what'd you guys end up doing?
Oh, well, surprisingly, the forceps thing never came out. They just kept trying to intubate, and I was just doing compressions.
Okay. So did you lose a pulse ever? Or was the patient in cardiac arrest?
Yeah, we lost pulse, and then by the time we're non-transport, so I heard later on they got to pull us back in the ER.
Why do you think it is they were trying to intubate instead of pulling it out?
Maybe they couldn't see it, I guess.
In some instances where you can't, in some instances where you cannot pull it out, it's better to push it down because you can push it down to the right side and you'll still be able to inflate the left lung. Some ventilation is better than nothing. Is I'm guessing what they were going with, and that's not wrong. Surgery can be done to remove whatever's in a lung. That's no big deal. That might be the only option with some patients. That, or we're looking at doing a cricothyrotomy or needle cric or a quick trach. These are some of the most terrifying calls you will ever go on. This is choking. I had a choking 2 months ago that turned into a stroke because the patient was coughing so hard. Patient stroked out. They're terrifying because you truly don't know what's going to happen by the time you get there. Tongue is the most common cause of airway obstruction. What does it sound like? What do you hear when you walk in and somebody's unresponsive and their tongue's covering their airway? What are you guys hearing?
Snoring.
It's like snoring.
Aspirations. A lot of times you can drop an NPA quickly, and that snoring will either diminish or go away totally. I cannot hit on enough your basics before paramedics. And, you know, I had a student in the day class, asked him why he was going through paramedic school, and he said, because I'm tired of being called basic and I'm tired of being, you know, called that I'm just an EMT. That is the most, what's the word I'm looking for? That is, that's horse crap. Let's just go with that. As an EMT, you have the knowledge to save somebody's life. You have the basics. You have the primary assessment. You have the ABCs, the compressions, the CAB. That is all basic knowledge. I'm not teaching you guys anything new with that you don't already know. But that's what saves patients. It's not, and it'll happen at some point, and I'll check you. During paramedic school, I'll give you a scenario of a patient in cardiac arrest, and you're gonna be like, okay, well, I want to IO the patient. I want to get the intubation stuff ready. And I do this in conjunction with the EMT class because I want to see how you guys react versus how the EMTs react. The EMTs will be sitting there doing compressions while you guys are trying to intubate somebody. Or they'll say, hey, do you want me to start CPR? And you're like, oh yeah, good idea. Let's do that. Because you get stuck in the mindset of, well, I have to do all this advanced stuff. You have to do basic stuff before you can move to advanced. Patients with altered mental status. These are the ones that I'm putting on the end title. These are the ones that I'm truly evaluating the respiratory status because, unfortunately, if they are not at a point where they can protect their own airway, maybe we look at taking their airway from them. Looking to see if we have proper air movement. I cannot preach enough on end title, and I will preach that throughout this whole year with you guys. Looking for chest to rise and fall normally with each respiratory cycle. Maybe it doesn't rise on one side. Maybe it rises on the left and not the right. Maybe it rises on the right and not the left. Maybe it's a case of trauma, like we had mentioned earlier. Maybe it's a spontaneous pneumo. There's so many different causes. Also, look to see how their breathing is. Are they tachypnic, meaning they're breathing fast? Are they bradypnic? They're breathing slow. Is it irregular breathing? Is it due to a trauma? All these different things. It might not be what's truly wrong with the patient, but it is a sign of what's wrong with the patient. Obviously, in our non-traumatic patients, we're using a head tilt chin lift. Trauma patients, we're doing a jaw thrust. If possible, a jaw thrust. I know that can be kind of difficult with some patients. A lot of times, reposition the airway. That's our first step in a patient that might not be breathing the best. Reposition their airway and see how they're breathing at that point. Then we can look at using an adjunct if we need to. Why the secondary assessment is important in conjunction with your ABCs, and one of the things that I want to know right off the bat, what is their history, what medications do they take, and what are they allergic to? Because medical history will tell me if something like this has happened before. And a good question to ask patients with respiratory problems is, hey, have you ever had to be intubated before? And they'll know. Have you ever had to had a tube put down your throat? If they say yes, that's an issue because they have severe breathing problems. I want to know what medications, and I want to know how new the medications are because I want to know if it's something that could be causing what's going on. I want to know what their allergies are. Maybe it is an anaphylactic reaction. Who knows? One drug that comes to mind when I talk about an allergic reaction to it is an ACE inhibitor, like lisinopril. People can be on lisinopril for years and then one day just experience an allergic reaction to it. ACE inhibitor-induced angioedema. their tongue will swell up and close their airway. It's actually more common than you think. BVM, obviously, make sure we're getting a good seal with the mask. Do not squeeze that whole bag. That is a pet peeve of mine. Please don't do that in front of me. Just enough to see chest rise. If you have to squeeze that whole bag, it's because you don't have a seal. It's not because their lungs are that big. What is their recent history leading to onset of symptoms? You know, in this day and age, I hate to say it, we're terrified of patients with respiratory symptoms. We're terrified of people having trouble breathing because we automatically think the worst. What time of year is it? What is the temperature outside? What is the humidity outside? That all plays a role into somebody's respiratory drive. Their past medical history. The thing that fears me the most is somebody having trouble breathing with no medical history. Okay, it might be easily fixed, but why are they? What's causing this? As paramedics, we almost become detectives at some point where we really have to dive into somebody's history and try to figure out them in a matter of minutes. And do a physical assessment on them. If you're not sure, start looking everywhere. Trauma is a big one. And you should know if it is a traumatic event. Observe the patient's condition. Maybe they're tripoding. Maybe they're in a position where their lungs are swinging forward. It's easier for them to breathe. Inspect for difficulty breathing. Look for any of the signs: coughing, sneezing, hiccuping, sighing, or grunting, especially in our peds. Some of the respirations that concern us: Kussmaul, so your maybe your patients with a high blood sugar, trying to blow off those excess ketones, trying to blow off that carbon dioxide. Shine-Stokes respirations, so maybe it is some sort of a traumatic event. Maybe they have brainstem trauma. Beat's respirations, same thing. Agonal respirations. Remember, agonal breathing is not normal breathing. When in doubt, start bagging your patient. This is the thing that the EMS providers, I hate to say, suck at. Please, during your paramedic rotations, during paramedic schooling, try to, as much as you can, listen to lung sounds. I get it. We're in the back of an ambulance. It's moving. It's bumpy. There's a lot of vibrations. There's a lot of noises in the back of them. One thing that might help if the patient is on the cot is put your foot on the bottom rail and push it down to the floor. It grounds it a little bit so you can hear a little bit better. Listen for snoring. So maybe we have a tongue obstructing. Listen for gurgling. So we have some sort of fluid in the airway. Stridor. What does stridor indicate?
Upper airway obstruction.
Okay, upper airway obstruction, right. Wheezing. What's that indicate?
Asthma.
Asthma or some sort of lower airway disease, right? Quiet respirations, a little bit scary. Maybe there is no air movement at all. Crackles or rails, rhonchi. If I walk in and I hear gurgling sounds, I'm terrified because that is a bad patient. They have so much fluid that they're actually gurgling, or it's just phlegm in their airway. Again, that requires immediate intervention. Palpate. Look to see if there is something such as a flail segment. Note the compliance if you're bagging this patient. Are they bagging effectively? Is there any issues? And note their pulse. Is their pulse slow or is their pulse fast? Pulse oximetry, the fifth vital sign. Again, there's other vitals. And I'm not saying pulse ox doesn't have a place. It does. But there's so many other things we can look for instead of relying on a pulse ox. I don't understand why we put a pulse ox on a patient and expect it's going to tell us all these magical numbers when our patients are having difficulty breathing. Again, all it does is measures hemoglobin that is saturated. That's it. And this is not correct. It does not measure the amount of oxygen that's saturated. It measures anything that's saturating your hemoglobin, not just oxygen. It is non-invasive, easy to operate. I get it. We all still use them. Some differences. Pulse ox is obviously looking at the amount of hemoglobin saturated. End-tidal is looking at the carbon dioxide level. End-tidal is real time. As you bag your patient, and that's one of the things we'll do in skills labs, is I'll stand there with a cardiac monitor in front of me and I'll put end-tidal on myself and I'll breathe for you guys. I'll hold my breath and you can watch as my end tidal climbs. I'll breathe fast like I'm anxious and you can watch my end tidal lower. Reflex changes, pulse ox in less than 5 minutes. It's kind of a big time frame. Capnography, reflex changes in less than 10 seconds. Now you can kind of see why I'll beat this horse. Now, what's great is when you use them in conjunction with each other. You don't believe pulse ox, put them on that title and see if what you're thinking is right. Hopefully I don't have to show you guys how to put a pulse ox on. Normal SpO2 reading, they're now saying 94 to 99%, again, because we don't want to go over 100. 94 to 99 is pretty normal. Only administered to patients who are hypoxic. As an EMT, we're taught chest pain. Guess what they get? They get oxygen, they get aspirin, and I'm driving them to the hospital. As a paramedic, you do not put oxygen on anybody unless they truly need it. Because, especially with cardiac patients, you can do more harm than good. Interpretation of what our hypoxemia is, so our low oxygen in the blood. 91 to 94 is considered mild hypoxemia, 86 to 90 moderate, 85 or less is severe. Again, that depends on the patient. I'm not going to say this for every patient because if I have a COPDer who normally sits at 83%, that's their normal. That doesn't mean that they're hypoxic, but their body is normal to is usually used to dealing with that. Some services, does anybody's service carry a CO oximeter? It looks very similar to a pulse ox. It's for CO specifically.
We do.
Where at?
Both in Mitchell County and in Garner.
Okay. Do you use it often?
Not very often.
Okay. Capnography, again, I will beat this dead horse. There's two components to when you put a patient on capnography. There's capnograph, which is actually your waveform. And then there's capnometry or capnogram, which is your numbers that we look at. You can look at PET-CO2, which is arterial end tidal. So if we draw labs on them, we can see what their carbon dioxide level is in their bloodstream. You can measure end tidal through either a nasal cannula, which is pretty common, or through an ET tube adapter itself. Most services have both of them. Whose service carries a colorimetric device? You put it on the end of an ET tube. If it turns purple, that means that you're not in the lungs. Verify placement. If it turns gold, gold is good. Does anybody use those anymore?
The service I used to run on, that's all we used when you first intubated, and then you added the end tidal on top of it.
Okay. Those colorimetric devices can give false positives for the simple fact that they rely off of acid that we exhale. They rely off that carbon dioxide. So riddle me this. If I have one of those colorimetric devices and I get some sort of acid on it, like vomit, what color do you think it's going to show? Do you think it's going to show good or bad? It's acidic, kind of like carbon dioxide. So it'll give you a false positive that you're in the correct area for intubation. That's why I hate colorimetric devices, because they are not always right. Again, our normal range for carbon dioxide is 35 to 45. And we've actually said that across the board. So when we put them on patient on, we're looking at 35 to 45. Remember that number, because you're going to need to know it for the rest of your schooling and for the rest of your career. Some sudden drops of end tidal. So if we have an end tidal of 34, 35, and then it starts dropping down to 0, maybe we intubated somebody in their esophagus. We have a failure with the equipment, or the CO sampling line is defective itself. Easy mnemonic to remember this is DOPE. What DOPE means is D is for dislodged, O is for obstructed, P is for pneumothorax, E is for equipment failure. Those are the things we start checking when we notice that a patient is going downhill, that we have intubated. Sudden decrease of end tidal. I'm not saying drops to zero, just a sudden decrease. Could be a leak in the system or a partial airway obstruction to where you have to suction your patient. Exponential decrease, maybe cardiac arrest, hypotension, PE, or we've just started bagging our patient too fast and haven't realized it. You can bag your patient based off your end tidal numbers. On the opposite end, sudden increase in end tidal, release of tourniquet. Why would that matter? If I release the tourniquet, why would that change somebody's end tidal?
You're holding all this CO2 and oxygen in the limb that's got the tourniquet on it.
You're absolutely right. Yeah, release it and then it goes into the bloodstream. That's why a lot of times before releasing a tourniquet, you'll see some services or some hospitals will give sodium bicarb to knock that down so we don't actually hurt our patient. Gradual lowering, hypovolemia, decreased cardiac output, gradual increase, hypoventilation is going to be your most common, or an airway obstruction. But we're going to play with the end tidal so much in your guys' skills lab. So some of this stuff you probably won't remember, but when we get hands-on with it, it'll be a lot more, a lot easier for you to grasp. Types of capnography, mainstream or side stream. Mainstream is you might just have a nasal end tidal that does nothing but end tidal. It doesn't have oxygen or anything with it. A lot of ones you can buy that are nasal end tidals that also have oxygen lines, and then they have a side stream line off it to hook into your cardiac monitor. And I'll show you those when we go to skills lab, the differences between them. Perfect example of your end tidal sampling right there. That is our adapter for end tidal with our sampling line coming off and going to our monitor to where we can see what we're looking at. So it goes in between your ET tube and your BVM. Some of the stuff we're going to go through in skills lab, ventilation perfusion mismatch, apnea, hyperventilation, all these can have a toll on your patient's capnography. One of the things we're going to hit on huge is your acid-base balance, and that is something that will confuse everybody, so I'm not going to get into it now. But when we get to that slideshow, or whenever we go through it, whatever chapter that is, you might want to pay a little bit of attention. I'll try to break it down as easy as I can for you guys. Most modern monitors, you'll see there, like the LifePak 15, allow constant monitoring of like end tidal and all your other vital signs. Be careful if you're hooking an end tidal line into the monitor. It's generally only a quarter turn. Anything more than that, you'll actually strip the threads out of it because they're really light threads. So you want to be really careful with that. That's it. A lot of the other stuff we're actually going to go through in skills lab with you guys. So let's get rid of that. I know if you're confused about some stuff, that's okay. Again, we're going to be covering this for a whole year. This is just kind of like your intro into it. There's going to be a lot more in-depth stuff, such as your acid-base balance, such as, playing around with capnography, playing around with end tidal. And like I said, we'll actually get it to where we can put it on each other and watch and see what each other's doing in conjunction with pulse ox, so you can kind of see the difference between how long it takes for pulse ox and how short it is for end tidal before it starts seeing a change in numbers. Any questions I can answer for you guys so far? I don't have any other slideshows or anything that we're going to go through tonight. This was the only one that I had planned through our syllabus for tonight because it was a quick slideshow. I'll try to make it. Honestly, I can't guarantee I'll get you guys out of here early every night, but I get it. I was a paramedic student that went through school at night while working a full-time job and a part-time job. If I don't have to keep you guys till 9, I won't. There might be some classes, I'll be honest with you guys, that, you know, if something comes up or something like that, I might record it and post it up for you guys to go through on your own time. And I might give you a homework assignment in conjunction with it, but I won't do that on really complex chapters. Maybe some of the easier chapters, I might do that for you guys, or we might just do it covered in skills lab or something like that. Any questions over any of the content that we just covered?
I do have one question. What was the acronym DOPE for, again?
So in our intubated patients, so patients that we intubate and we see a problem happening, whether it be end tidal drop, drop in pulse ox, or it's hard to bag them. We use the mnemonic DOPE to look at the things that could be potential failures. So the D stands for dislodged tube. The O is for an obstructed tube. Maybe you need to suction the patient. P is for pneumothorax. And then E is for equipment failure, such as a bad ET tube or a cardiac monitor port that's went bad.
Thank you.
Something, again, remember that. I can't preach enough. A lot of the stuff we teach you guys, honestly, going through paramedic school, you're going to have to remember a lot of this stuff. And please, you guys have books, rely on your books. Use your book as your friend to get through everything. It can be a little difficult, and at times it's going to feel chaotic. Like maybe you're not learning anything. And I promise you, halfway through the program, I'll check all of you as students to where I'm saying, okay, I want you to explain to you that started the program 8 months ago about end tidal. And you'll realize how far you've actually come. Mercy has a great pass rate. We have a good placement rate. We have a great success rate. From the last class, I can tell you I have 2 people that have already passed the National Registry, just because they worked hard during paramedic school and they did what they needed to do, and got their stuff done. Please don't fall behind if you don't have to. I get it, things come up and you can't come to class some nights. I'm not going to fault you for that, but please try not to fall behind, because once you fall behind, it can be a little bit difficult trying to catch you up.